Neurology quiz number 111. Discuss the pathology, complications, and management of carotid webs. A carotid web, or CAW, is also known as a carotid diaphragm, is an atypical intimal variant of fibromuscular dysplasia. They have been established as a cause of stroke, especially in young people without traditional risk factors. CAW is characterized by a fibrous, shelf-like intimal flap originating from the posterior wall of the internal carotid bulb, projecting into the arterial lumen. CAWs are thought to be a type of focal intimal fibromuscular dysplasia without calcification or atherosclerosis. Overall webs are believed to represent focal hyperplasia of the tunica intima, although their development remains poorly understood. This picture shows a CTA in axial projection and demonstrates a carotid artery web shown by the arrow projecting from the posterior wall into the lumen of the carotid bulb. Here the picture on the left shows a carotid artery section demonstrating a carotid artery web. Histopathology of the carotid artery web on the right shows fibromuscular intimal thickening. Note the normal aspect of the media and adventitia without calcification. Carotid artery webs rarely cause hemodynamically significant stenosis. However, studies have consistently observed pooling and stagnation of contrast just beyond the carotid artery web on diagnostic angiography. Additionally, thrombi have been directly visualized on carotid artery webs in some cases. The underlying mechanism of stroke in a carotid artery web likely stems from recirculation of blood distal to the web because of disruption of normal laminar flow. This leads to elevated risk of platelet aggregation, stasis, thrombosis, and ultimately cerebral embolism. This picture shows thrombogenesis in the ICA due to the presence of a carotid web. Stasis of blood flow developing distal to the carotid web results in thrombus formation. This thrombus, when of sufficient size, dislodges and embolizes intracranially. This picture shows a carotid artery web with contrast spooling, demonstrated by the yellow arrow related to the web, and is seen on catheter angiography. The overall incidence of carotid artery webs is largely unknown. Among non-stroke patients, carotid artery web prevalence may be as low as 1%. Carotid artery webs are associated with younger age, African American race, and female sex. Literature suggests that the incidence of carotid artery webs among younger patients, that is less than 60 years with otherwise cryptogenic strokes, ranges from 10 to 20%. Approximately half the patients with CAWs harbor bilateral lesions. For patients with a stroke found to have ipsilateral carotid artery web, the risk of stroke recurrence is high. In a study of patients with carotid artery web associated stroke, or TIA, overall stroke TIA recurrence risk was 4.4%, 10.8%, and 19.8% at 1 month, 1 year, and 2 years. Carotid artery webs are an important but potentially overlooked risk factor for stroke and may be associated with a high rate of stroke recurrence. Neuroimaging of CAW. CAWs are often best visualized on oblique views, irrespective of the modality used. CT angiography. This is the most commonly used method of CAW detection because of its non-invasive nature and the fact that it delivers rapid, high-resolution images. CAWs appear as thin defects along the posterior side of the carotid and may be seen as septa or filling defects. This picture shows a CTA sagittal view which demonstrates a presence of a CAW as indicated by the white arrow. As oblique views are best for visualizing CAWs, multiplanar reconstructions, or MPRs, are essential for diagnosis. In the absence of such techniques, the lesion can be missed or misdiagnosed as an atherosclerotic plaque. Atherosclerotic plaques can be mistaken for carotid artery web, but are often circumferential and not limited to the posterior wall of the carotid bulb. In addition, their surfaces are irregular and associated with calcification. Carotid dissection can be confused for a carotid artery web, but usually starts above or extends beyond the bulb with enlargement of the vessel diameter. This picture shows a normal carotid artery as well as an atherosclerotic carotid artery with circumferential involvement and irregular surface. as well as a carotid web projecting into the lumen. This picture shows images from a patient with carotid stenosis due to cholesterol plaque. The narrowing is not shelf-like and there are areas of calcification which are usually seen in cholesterol lesions but not with carotid web. DSA, although often considered as the gold standard for diagnosing CAWs, it is not necessarily superior to CTA. Therefore, given its invasive nature, it is not recommended as a first-line modality. It can show contrast spooling in relation to the web in the late venous phase. MRI and vessel imaging. Its advantage is that it provides detailed imaging without using radiation. It also allows examination of the surrounding vessel wall and identification of potential vasculopathy. However, it is not as sensitive as CTA or DSA because of its lower spatial resolution. This picture shows a typical CAW seen on catheter angiography. Carotid ultrasound. This technique shows CAWs as bright structures that project into the artery and alter the flow patterns seen on Doppler imaging. It is non-invasive and cost-effective, but it is difficult to distinguish CAWs from other vascular anomalies such as dissections and plaques. Optical coherence tomography. There are some reports that intravascular OCT can be superior to other modalities in detecting CAWs. However, more data is needed to validate this technique. This picture shows a color flow and B-mode carotid duplex demonstrating CAW in a stroke patient. CAW shown by the red arrow. White arrow clearly demonstrates turbulent flow and stasis in blue distal to the CAW with anterograde systolic blood flow in red in the internal carotid artery. Guidelines for imaging. Patients with embolic stroke who are less than 60 years of age and do not have traditional risk factors for vascular disease or stroke have a higher likelihood of having CAWs. In such cases, CTA should be considered as the first-line modality to image neck vessels. In performing CTA studies, multiplanar reconstruction, especially with oblique cuts in the plane of the carotid bifurcation, is the optimal technique to detect CAWs. MRA and carotid ultrasound can be used as supplementary studies in cases with atypical lesions. For the typical CAWs, DSA should not be required. It should be reserved for patients if there is diagnostic uncertainty or in those patients who are being considered for carotid intervention. Treatment, medical treatment. There are no evidence-based guidelines for managing CAWs. Current guidelines recommend antiplatelet therapy for symptomatic CAWs. A survey conducted by the Society of Neurointerventional Surgery revealed that medical management with single or dual antiplatelet therapy is considered as first-line treatment by most providers for symptomatic CAWs with a previous history of stroke or TIA. Antiplatelet agents are also recommended for asymptomatic CAW. There is limited data regarding use of anticoagulants. One systematic review did not show any significant difference in stroke recurrence rates between antiplatelet agents and anticoagulants. Carotid intervention. Young patients with cryptogenic stroke and CAW have a high risk for stroke recurrence, and recurrent strokes can involve large blood vessels. For patients who have multiple ischemic events secondary to CAWs, current recommendations include considering carotid intervention. Carotid stenting. This procedure is effective and safe. In one study, stenting CAWs completely prevented recurrent strokes in 24 patients during the follow-up period of 12 months. Many studies have shown very low incidence of periprocedural complications. Carotid endarterectomy. This has also been shown to be safe and effective. To date, there is no comparative data for efficacy of various surgical CAW treatments. Available data suggests that carotid intervention is both effective and safe, with low rate of periprocedural complications, and is superior to preventing recurrence of ischemic events and as compared to medical management. Current data suggests a high rate of stroke recurrence risk in symptomatic CAWs that are treated with medical management only. Surgical intervention with carotid artery stenting or endarterectomy should be discussed with patients who have otherwise cryptogenic strokes related to a carotid artery web. Surgical management in asymptomatic cases should be addressed on a case-by-case basis. This picture shows that carotid stenting displaces the dysplastic segment against the vessel wall and promotes long-term neointimal formation along the stent, eliminating future thromboembolic events. Conclusions. Carotid artery webs are non-atheromatous shelf-like projections arising from the tunica intima of the posterior carotid wall. They are suspected to be a cause of cryptogenic stroke and should be especially considered in younger patients presenting with large vessel strokes and without traditional risk factors. CTA with MPR should be considered as the first-line diagnostic modality. Recurrence of ischemic events can be high with medical management alone, and both carotid stenting and arterectomy are effective as well as safe in preventing future TIA and stroke.